talking about the technique and controversies of CCSVI treatment. He is a fellow of the Society of Interventional Radiology and co-founder and director of research at the San Diego Cardiac and Vascular Institute. He has authored or co-authored over 50 scientific articles and book chapters and has been a frequently invited lecturer or scientific presenter throughout the world over 150 times. His research has included the design and development of endovascular stent grafts for both the TIPS procedure and for the arterial applications. Dr. Saxon earned his medical degree from UCLA, Alpha Omega Alpha, completed a radiology residency at UCSF, and did his fellowship at the Daughter Institute of Interventional Therapy at OHSU. He remained there as an assistant professor of interventional radiology until 1997 when he moved to a private practice in San Diego. He is one of the 3 IRs performing venous angioplasty as part of the Hubbard CCSVI study in San Diego.
How's everybody doing? On stretch, I do. It's 3 in the afternoon and I'm falling asleep. So I am the last interventionalist to speak, so I will be the last catheter jockey, and I'll try and keep this somewhat entertaining. And I don't know what, Mike, but I started at UCLA, so if I got kicked out, what does that mean? So what I'm going to talk about is sort of, this is geared a little bit more towards patients than doctors, but a little bit in terms of what we need to do as interventionalists and doctors in trying to standardize our approaches as we move from sort of initial experience to trying to design trials that we can maybe move this science forward. So what are the treatment option basics right now? Well, I think the first one is try to do as little harm as possible in the infancy of any technique. Because number one, we don't know exactly what we're doing for our patients, but number two, the more problems we run into, we might set the science back as well. Current researchers need to quickly try and standardize treatment techniques so that we can actually get into trials with one technique. And that's going to be very difficult in this setting, and I'm going to sort of touch on some of the stuff that Mike talked on about why I think that's pretty difficult in CCSVI. And then I'm just going to go through a touch base on a couple of topics in regard to what Dr. Gooding was talking about, and to discuss many of the claims of superior treatment approaches that are now appearing on the web as this becomes commercialized, which I'm fairly concerned about. One of the problems with standardizing technique is we don't have standard lesion types. There are a number of variety of lesion types that you've already seen today, from stuck valves to valve site lesions to extrinsic compressions to stenoses and occlusions, and et cetera, et cetera, et cetera. And so to say we're going to standardize a technique that we can use in a trial means that we have to figure out a technique that works for all of those lesion types, and that's pretty difficult. We're not going to have one technique for all of those different lesion types. And because they have different potentials for success and needs for treatment. So we really haven't yet determined what works best, and that's going to make embarking on a randomized trial rather difficult. Not to mention the issue with finding somebody to pay for it. Some are common sense issues, and we can learn a lot from what we've done in other areas, and that's what I'm going to talk about a little bit. So what are our current treatment options? Well, Justin went through most of them, as did Mike. Balloon angioplasty is sort of the basic. You hear a lot about high-pressure balloons, so I'm going to touch a little bit on that. There's the idea that maybe we should be primarily stenting all of these. I think most of us are staying away from that for now. I'm going to talk a little bit more about cutting balloons and other techniques such as atherectomy and cryoplasty that people have proposed using in this situation. And you see a lot on the web of this parallel wire technique of putting wires outside the balloon. What does that mean? Is that useful? What is this all about? So just as an example of the fact that we are seeing a lot of different lesions, here's that valve site stenosis, here's a carotid compression, and here's a high jugular occlusion. And if you look at all three of those side by side, you can say, well, yeah, we need different techniques to treat all three of those things. So it's going to be a little bit difficult. So I'm going to talk mostly about beef as to what we know from previous studies and try and stay away from what I don't know. What we know about balloon angioplasty is it's the only technique that's really been tried by Zamboni and CCSVI, and then there's been a number of other studies such as our own that shows that it's relatively safe, relatively low major complication rates. And one of the things I noticed in reviewing Zamboni's work is that all of his restenosis generally occurred in the internal jugular veins. He had a 47% internal jugular vein restenosis rate, with a 16-fold lower restenosis rate in the azygous vein. Well, he used only 8 to 12 millimeter balloons. He never used a balloon greater than 12 millimeters. Well, a third of the jugular veins we see are in the 14 to 18 millimeter diameter when it comes to the lower valve site. So these were technically undersized treatments, which may lead to a much higher rate of restenosis. Now, this is not to criticize Dr. Zamboni. This is to talk about the fact that, yeah, we really need to look at this and standardize these techniques and figure out what's really going to work before we start doing a trial that says that we have a 47% restenosis rate. Because if you look at the data so far, we don't really know what our restenosis rates are in the vast majority of people's experience. So that's just a basic principle of PTA, is to size the balloon properly. I'm going to talk a little bit about restenosis, which occurs everywhere. Restenosis is fibrous scarring and re-narrowing of vessels that occurs anywhere from 1 month to 2 years after treatment, and it's seen with all arterial and venous interventions. This is not something unique to CCSVI. If someone really solves this problem, they're going to win a Nobel Prize. If they can come up with a magic bullet for this, it's like a magic bullet for cancer. And it's a ubiquitous problem, and therefore it is very complicated. And we've been working on this problem for 20 years, 30 years, and we haven't solved it. We have some ways of making it better. And so when you look at this restenosis cascade, you can see that it is extremely complicated, with an inflammatory process that leads to multiple release of proliferative agents that leads to extracellular matrix deposition and smooth muscle cell hyperplasia and fibrous tissue buildup, to the point that it is not simple to find a solution. There have been many techniques suggested for the treatment of restenosis and prevention of restenosis, and most of them have failed. One of those was cryoplasty, which is a freezing balloon. And the thought was that you would inactivate smooth muscle cells so they wouldn't scar. That has shown no benefit over PTA in terms of patency, or in dialysis fistulas in terms of patency. Atherectomy is another technique that is used routinely in arteries, in which disease is shaved out of the inside of arteries. And although it's been used for 10 years to 15 years, actually 20 years, I've never seen a paper showing patency data that's any better than angioplasty alone for atherectomy. It does work, but it doesn't last any longer than angioplasty alone. High pressure balloons have been proposed on the web as the solution to CCSVI on some sites that I've seen. But really, we use them routinely to overcome blockages that are difficult to overcome, because we have to. We have to go up to higher pressures to get the stenosis to open. But it causes more barotrauma to the artery, and until some of this theory on CCSVI, our routine understanding of it was more barotrauma was not necessarily good. It might actually precipitate more restenosis. So there's really no evidence in terms of restenosis that high pressure balloons are of benefit. So what about cutting balloons? Well, Justin touched on cutting balloons. I just brought a little video so you can see how they work. They've been tried in a number of different areas. This is what one looks like over here. It has little blades on the outside of the balloon that are tiny. The theory was that that would lead to a controlled medial injury and a controlled injury to the intima that would lead to less restenosis, because you'd be causing less damage than you would with, say, a high-pressure balloon. And I see a lot of shameless self-promotion out on the web. We're the first to use this novel technique in CCSVI. We use buddy wires. We use radiofrequency recanalization wires. We know how to do it. Nobody else has done it. But I would suggest that the buyer beware, because none of these things are new. Most IRs are experienced with these things and have tried them. And they all have failure rates. So when somebody says it works and it doesn't fail, I will challenge them. There's no difference in patency for cutting balloons in large randomized trials in the coronary arteries versus angioplasty. There's no difference in patency in dialysis fistulas for cutting balloons relative to regular old angioplasty balloons. They are approved because they showed equivalency in dialysis fistulas relative to angioplasty. They were no worse. So they're out on the market and we can use them.